I get the privilege of starting today with some basic information. As most of you all know, Friedreich ataxia is a rare genetic progressive degenerative disease of children, adolescents, and adults. It affects about 1 out of every 50,000 people, but is affected in some way, not necessarily directly, all of us within this room. Typically, we think about Friedreich ataxia as a neurodegenerative disease. That's what you read in the textbooks. But really, as you all know, it's a multiple system disorder. The neurologic dysfunction is simply the common denominator and perhaps the most visible sign. Rob Wilson and Massimo Pandolfo will be talking a lot about the pathophysiology, but in order to talk about a couple things which I'm going to mention in a minute, I have to remind people the genetic abnormalities and expansion of a naturally occurring GAA repeat in the intron, which leads to deficiency of frataxin, difficulty with mitochondria, and cellular dysfunction. Those things lead to neurologic dysfunction, as well as all the other clinical features of the disorder. So that's the amount of background I'm going to give in order to give my talk. So the other things which I'll mention are, since we don't have a cardiologist specifically speaking about the heart and Friedreich ataxia today, though our cardiologist from the Children's Hospital Clinic, Kim Lin, will be here with us for the question and answer session on clinical matters just after lunch. I'll remind people the heart is affected in Friedreich ataxia, both with cardiomyopathy, what we call degenerating or abnormal heart essentially, as well as giving rise to funny heart rhythms, the word we use being arrhythmia. Remember that as physicians and scientists, we like to make up lots of words for the simple purpose of confusing you. It's a talent they teach us in school. In most individuals, the cardiomyopathy is of a hypertrophic nature, where the heart grows in size, the muscle becomes thick, and that can lead to difficulties as well as long-term changes. And it is the most common cause of mortality long-term now, is what we've even studied recently. People do have EKG abnormalities, which don't necessarily mean anything, but will look like a person's having a heart attack when they go to the emergency room, even though they're not. But people can have the funny heart rhythms called arrhythmias, which can lead to difficulties. Our second speaker, Steve Willey, will talk a lot about insulin resistance and diabetes and the results of studies we've done recently. And then, as many people know, curvature of the spine, scoliosis, is present and could require surgery in about 50% of people in some studies. So that's our background. That's what I think most people knew before they came today from the textbooks. I get the task of talking about neurological issues. Now, while we talk about cardiac disease as the cause of mortality, the long-term disability is mainly caused by the neurological dysfunction. You can go to any neurology textbook or Wikipedia or whatever, and you can probably read about the classical form of it. Well, we want to rethink things a little bit here, because with the past 10 years, we've entered a different era, the era where we have new potential treatments, and our job to try and treat things to make them better. So we have to sort of think about it in a very different perspective and think about what our goals might be. Normally we use neurologic function to diagnose, but now this is a different era. We want to think about treatment and greater understanding so that we can move forward. So I'm going to review a little bit about the neurology and nervous system of all of this, and then we're going to consider some new questions. So I'll start at the beginning. Most of you know that we talk about the brain and your nervous system as a computer, and this computer is composed of two types of processes, let's say. A cell body, you might say the chip, and then a long wire called the axon. These are connected together to give rise to the computer, which is your brain. Of course, I've diagrammed it as two cell neurons here. Your brain has about 10 million neurons, so it's a bit more complex than I could ever draw without making an absolute mess of everything. But this is the prototype of what we talk about. So if you read a textbook, what do you see? What you see in a textbook is that what happens in Friedreich ataxia is a slowly progressive loss of the large sensory neurons, particularly the ones which are concerned with what we call proprioception, where your limbs and body is in space. That is, the signal is not getting to your brain where your hands are or where your feet are. Now, that's a crucial component of balance. In addition, there's a loss of a long pathway, a wire, which we call the spinocerebellar tract. Now, again, we like to make up words, but I'm going to make a bet that most people have figured out that this is the track which goes from your spinal cord to your cerebellum. And actually where the cerebellum, as it were, makes that comparison between what you want to do and what your limbs tell you're doing, so that's a particularly important track, albeit I'll show you in a minute, it is impressively small. There's also, to a more modest degree, loss of the motor tracts, which start in your brain and go down to your spinal cord to tell you to move, giving rise to some loss of motor control, but less weakness than we see in terms of balance. There's also a very small area within the brain called the dentate nucleus of the cerebellum. dentate. It looks like a tooth on sections. I think that's why they named it that way. So it's lost in FA, but it tends to be lost somewhat later. And then a few other sites. You know, it's not like the brain is entirely abnormal. That's important. The cortex of the cerebellum, as well as the cerebral cortex, that area which we all use to think, to speak, to do the things which make us, for lack of a better phrase, is largely intact. If you were to add this all up, it's probably maybe 2% of the neurons in the brain, some small number of like that, and maybe 10% of the long wires. Now, that's not that much. That's important because when we talk about the therapies we're going to talk about, the question is always, well, how much will recover? Well, we don't know. But we know that we'd much prefer to start with 98% of neurons still being there and 90% of the tracts than anything else. So the potential for recovery is there once we figure out how to slow or stop disease progression. So one step at a time, but we know that potential is there. So what does this mean? The loss of the large sensory neurons gives rise to a loss of balance because you don't know where your limbs are. For those people who are electrical engineers, the cerebellum can be thought about as a differential amplifier and where you compare the movement you want to make with the movement you are making. Essentially, if you don't have the information coming in on what you're doing, you're going to lose your balance. That same thing is coded in those very small spinal cerebellar tracts. Once you get into the cerebellum, that back portion of the brain itself, which I'll show you in a minute, there you have some other issues, speech difficulties, some eye movement abnormalities, and probably some other features later on. And then a very few other sites. A few people know that vision and hearing can be affected, particularly later. Those are those few other sites which we mentioned. But remember, people's cognition, as you would know for me, is largely spared. You know that because you're holding your jobs well, you're doing all the things you did 15 years ago, but just superimposed with a motor burden on top. So this is, I have to show a picture. This is a picture of a spinal cord, obviously at autopsy. The one on the left is out of a textbook. It's, quote, normal, except it's been colored yellow and green. You know, most of our spinal cords aren't yellow and green. The one on the right has Friedreich ataxia. And this area right here, the blue area is normal. Over here, the black area is normal. This area here, the cell bodies, that's normal. What actually happens in Friedreich ataxia is the cells that are lost are these right here, which sit right outside the spinal cord, called the dorsal root ganglia, where the sensory neurons are, particularly the large ones which are concerned with where your limbs are in space. The others tend to be more spared. They send a branch, a wire, into the spinal cord, such that into this area right here, which you see goes away over time in Friedreich ataxia. The only other things that you see which might be missing here is there's a little bit of the motor tract loss right there, which carry the fibers going down to control muscle, and this little ditzel, as I like to call it, right there, which is called the spinal cerebellar tract. It's a very small pathway, but is crucially important in the clinical manifestations. So this is what the spinal cord might look like. This gives rise to that loss of sensory information and that sense of balance. So when we look at the anatomy and what's really going on, the things which are going on are just these two small things here at the spinal cord level. Not a whole lot. Think about that's the most affected area in the central nervous system in FA, and still it's not everything that's affected there. The other place, there we are. This is a section through a brain which would cut down the middle. We call it sagittal for those words. And this is, if you look at it here, where's my pointer? This is the cerebral cortex. It's all the area that you think with, that you speak with, that you see with after the eyes, that you hear with after the ears. That's a fiber pathway there. This is the cerebellum, which is concerned with balance back here. And if you were to go just past the midline and make a little dot, about the size of a half of a small marble, you would find a nucleus called the dentate nucleus. That would go away over time in Friedreich ataxia, but basically the rest of the brain at first glance, and as we look at it classically, would be normal. So the message and what that gives rise to, oops, I'm going to go back. What that gives rise to is perhaps the loss of speech and the speech dysarthria, as well as some of the truly cerebellar components of the disease. So if you really want to understand this, we need to look at the simplified wiring diagram of the cerebellum. Here we are. We'll be having a test on this in just a very few minutes. Massimo and I will be passing it out. We'll see how the people at the first table do. So no, you don't need to know it in this much detail. In fact, do we need to know it in that much detail? That's an interesting question, but we can look at this very simply. Think about this in Friedreich ataxia as opposed to the other ataxias you may meet people with in support group. You lose the input coming from your joint receptors where your limbs are in space, so you have difficulty making that actual comparison. You also lose some of the dentate nucleus down at the bottom, so you lose a bit of the outflow, particularly later. But it's a relatively simple scenario. What does this really mean to you? When we see people with Friedreich ataxia, a lot of it is going to be dependent on knowing where your limbs are in space, and if you don't have those joint receptors, you don't have that sensation, you're going to use your eyes to do so. As you know as well as I do, the balance difficulty will be very dependent on visual input. Yes, there are other features, but that's something that you can remember in everyday life to help you walk better, is simply to use your eyes and use your brain. Your brains are intact. It can help you out a whole lot. I wish I knew people who remembered that. So the neuroanatomy is actually very simple. You can read this in a textbook. Why do we think about it? Well, our job now is not simply to recite this, as we can do quite well, but we want to try and figure out how to make people better and really improve them with the new generation of drugs, which we'll talk about in a few minutes. Well, I think it's common sense, but often forgotten, that if you want to make someone better, you have to prove it. And how do you prove it? Well, you have to be able to measure it. How do we do that? So let me see, probably about half the people here have come to see either myself or Dr. Pandolfo or one of the other neurologists, and you'll see us go through an exam with you. And you'll notice that I'll call out some numbers to Sean or Carla or Lauren. Sometimes I'll even flash them behind my back like a catcher making signals. You know, that's a faster way, although I shouldn't bring up baseball after last night's game. What are we doing? We're doing a very standardized neurological exam where we're looking at very specific things and how far a person shakes in a certain amount, how accurately they touch the top target, how long they can stand for us, whether you can bring out reflexes, how long they feel a tuning fork, so that we can quantify a neurological exam. That seem like a good way to measure the disease? I don't know. It's what we do, it's what neurologists do, but many people know that neurologists are basically useless. I'm a neurologist, I can say that. So, is that really a good thing? And that's actually an issue. We call this exam the Friedreich Ataxia Rating Scale, or the FARS for short, because it takes entirely too much time to say Friedreich Ataxia Rating Scale. We call it the FARS for short, and we've done studies that validate that we can make neurologists pretty similar if we really instruct them. But there are issues with this. I think, as you all will know, not every neurologist, no matter how much training you do, is going to be the same. That's just what we'll call human nature. If Susan Perlman and I and Massimo rate the same patient, or the same series of patients, I bet we have the same rank order of it and what the numbers are, but the numbers, no matter how much training we do, may not be exactly the same. What does that give rise to? Variability. And when you're trying to rate how someone is doing and make them better, variability is your enemy. You want things as uniform as possible. So if we were to clone Massimo and pass him out to 7 different sites, it would be quite easy to do a 7-site trial, but you know, we're not against that. We're not going to do that. Other questions about doing these things, besides the fact that it's semi-subjective, will never be quite the same. You can give me an honest opinion here. When we do these tests on you, do you think this has any bearing on your day-to-day life? No is an perfectly acceptable answer. And that's a very good point. Our goal is not to make neurologic exams better, it's to make people better. And while we might use the neurological exam as a measure of that, our goal is really to make individuals with Friedreich ataxia better. So there's certain aspects which may not be relevant. It's important for you to ask us, but it's also important for another matter. This is what the FDA asks us. They'll take these exam scales, but really they would like us to prove that it means something in people's lives. To a certain extent, that's why we ask all those other questions about your life and how you're doing all these different things so that we can correlate it. But the FDA would really like us to really prove that people are better in a way which is relevant to their life. And the final thing is all these things give rise to what I'll call a lack of sensitivity. Ideally, you'd like to be able to do a study with the minimum number of patients which you need. Why? I think everyone would give me that it's a lot more expensive to do a study with 100 patients than it is with 50 patients in terms of effort, money, time, travel, things like that. If you could have the most reliable measures, you'd be able to do the studies with fewer and fewer individuals. Or another way is as the drugs get better and better, you'll be able to show add-on effects of one drug on top of the other with smaller numbers of people. That's why we keep doing these things every year when you come back to see us and visit us, and that's why we'll be seeing 20 people between yesterday, Thursday, and Monday to help evaluate that. This is how we learn and how we make better measures. It's important to you because when you come for clinical trials, and notice I use the word when, this is what we'll be doing, and this is what we'll be doing to measure things so that you understand exactly why we're doing things. Is there another way that gets around this exam-based problem? Well, maybe we should just have people do some tasks. Or torture, as we sometimes call it. We call these performance tests, timed measures where you get rid of the neurologist. Always a worthwhile thing in most people's mind. No neurologist to be subjective. You just see how fast people put things in a pegboard, how fast they walk, whether they can read a vision chart, how fast they can speak a certain set of words, though some people can speak a little faster than others. And it has nothing to do with disease. These are ways we can time, and no one's going to argue about. We set up the rules on how we time them, you know. There's no interpretation. They're objective. They're relevant to lives because, you know, people care about how fast they walk. People care about whether they can do fine finger movements, though not necessarily putting pegs in a pegboard. Maybe we should have like a typing test, but I'd lose that one so badly. People care about whether they can read and whether they can speak. These are very relevant. In fact, the FDA likes these a lot better than neurological exams. So I can leave now, and the neurologist isn't necessary. The issues are, these tests tend to work over a narrow range. For example, a timed walk isn't useful in people who are having sufficient difficulty walking where they don't walk well. The pegboards are only useful at certain points. The vision is a later stage feature of FA. If we combine these together statistically, we can make a composite which works over the disease, but this is a somewhat new concept that is only now being accepted. So that's one issue with these nice, highly quantifiable timed measures. In addition, suppose you break your hand. That is going to affect how you do a pegboard, even though I might be able to account for that in a neurologic exam. So there's some confounders there, and certain random events might be going on. Suppose you trip while you're doing the walk and you fall. That's really just something that happens every once in a while, but we don't have a really good way to account for that, so random events can intervene. So which one do we want to use? The answer is each study that you do neurologically is a different experiment, and I want to come back to the fact that every time we do a clinical research study, whether it's a natural history study, or a drug study, or a blood study, it is an experiment. You want to use the one which is best for that particular experiment. Wow, they sent me to school to think about that. Oh my gosh, what a waste of society's money. So in fact, that's why you see us doing all these even within the same event, and you want to be sure that they at least all go in parallel. Even if within a given study, we have to take one and call it the primary measure, and it's the one we're really going to count. So this is the reason we think about the neurology, and we're going to do timed exams and performance measures which work on those look at those neuroanatomical components I said before. So now, I am going to go forward and talk about the 3 trials that actually 4 trials we have participated in here from neurologic function. In the question and answer session later, you're perfectly welcome to corner Dr. Pandolfo on those he's participated in as well. You love me, don't you? You were expecting it. When you read about clinical trials, because now this is the information era, you'll see the abstracts, you might see the full paper. You'll want to understand what you're reading, not just trust us. The things you'll want to notice. What disease stage were participants? How affected? Was it only ambulatory people, or did it include everyone? Was it only children? These are things which affect the results and affect the interpretation, both good and bad. There'll also be something about who did they get to come for the trial. You know, does it say 50 people showed up for the trial, but 50 people showed for the trial, but 20 of them dropped out? You know, you would wonder about the meaning when that occurs. What happened to the other 20 people, and why did they drop out? That's an important thing to understand because it might skew the results. How long did the trial go on, the trial duration? This is a particularly important component. Let's suppose something works if we give it to someone for a month. What happens when you give it and people get better? What happens if you give them to 6 months? Do they keep getting better still, or even better? Or did it just get that little bump you saw at 1 month? Or is the body smart enough to realize that whenever we give someone a drug, we're trying to trick the body? and the body's smart enough to recover its abilities and go back to the abnormal state 6 months later. How do you figure these things out? You do the experiment. And if you don't do the trial, you can't figure out what happens. Or you can sit up here and wonder what happens at 1 month versus 6 months. And you can never be wrong, but you'll never be right. So let's talk about the 4 trials we have done in the past 4 years. Now remember one thing, as we talk about this, that's 4 more than we're talking about in most other disorders that we take care of. So these are the first steps toward that eventual goal. The drug called Idebenone, a series of studies performed in recent years. I guess if we add them all together, it's probably 8 to 10 studies. The ones I'll mention very briefly here are the so-called NIH Phase 2 study, which was done around 2005, and then the American Phase 3 study, which we did at CHOP and UCLA. The NIH study was called Nicosia, if you remember that. The Phase 3 study here was called Ionia. That's because Santhera names all their trials after cities in Greece. I don't know. You know, someone has to know those things. In any case, they're very similar. Both are 6-month studies. Similar doses of drug, though not exactly identical. The Phase 2 had 4 doses. We only had 3 doses, one of which was placebo in each. Now, they gave different results. Why? Well, let's take a look at those there. Okay, and what I have here, and this slide is given to me by Thomas Meyer from Santhera, though it's publicly available data. He did give me the slide. And what I'm looking at here is if we go up, because my pointer is burning out a little bit, up is bad, down is good. And they're looking at the difference in people's exam scores done with an ICARS rather than a FARS, but that's not important here. It's very similar. People get the 2 doses, and they get better when they do it at the NIH. When they go to UCLA or Philadelphia, the blue is the placebo group here. The placebo group gets a little better, and the people on drug get a little more better, if that's appropriate English. So what happened? Why are they different? Well, you never know those things, so you have to think about this sort of stuff. We don't know exactly what, but I'll come back to those in a minute. So now let's do something else. So that's trial number 1. There's actually a second trial on what we did, and this is new since we talked last a year ago. We took the people who got in that Phase 3 study, and we put them all on drug for 1 year. And I know some people in the audience participated or their children participated in this. And then you compare to how people would have been expected to do had they just been living out in the community, what we'll call a natural history control group. So what happens? This is what happens, and I'll take you through this, again prepared by Thomas out of convenience. Again, the data is being published. I believe it comes out probably next month. It's already available online. This is the start of everything. And as you saw, people on average, even including the placebo, got better, but just a little bit in that 6-month study. And then you keep giving them Idebenone, and what happens? Well, they get a little bit worse, but they're not back to where they were when they started to 18 months earlier. So that's really good evidence that Idebenone is a great drug, right? No. There's no placebo group here. How do we know that we just didn't take some people who were really uncomfortable with people who talk really fast and bring them to the office, and by the time they got to the end of the trial, they were really comfortable with people like me? It's possible this is entirely practice, as we had them do their pegboards and we had them do these complicated exams. You know, you wouldn't want to see it go the other way where people got worse, but you can't use this as great evidence that it does work. So, again, we have the quandary of does it work one day and not work the next? Don't know. And it does give us to a problem. So how do you actually interpret this? Because in the end, we don't care as much what happens on those slides as what happens in real life. And because Idebenone is generally available over the internet, there actually is a question here. Do you take it or not? And I'm not going to take a position while I'm up here right now, but it's a really good question. Are the side effects less or better than the potential side effects, less or better than the potential benefit? I do have an opinion, particularly based on the fact that it has very few side effects, but you can't sit up here and say that it has been shown to work. You think it might, but you're not sure why. Well, why might it have been different between these different studies? Well, the observers change. I mentioned those exam-based rating scales. In the second study, it's Susan Perlman and I rating, who have seen, probably with the exception of Dr. Pandolfo, more individuals with Friedreich ataxia than any in the world. Our exams are very practiced in. The individual in the NIH study was naive to Friedreich ataxia. They will rate perfectly fine and perfectly consistent, but they'll rate different than we do. Who's right? No, neither is right. They're both internally consistent, but things will happen as you do these studies. Not everything will be a clean result. The other catch is the first one is one site. That person is almost by definition internally consistent. Instead, if you take it to 2 sites, you're going to see more variability. I remind you of this for things which I might show in a later slide. When you go from one site to more, you will see more variability. Count on it. Maybe it's different selection criteria. In the first NIH study, they took anyone who was a child. We were required to recruit ambulatory children. So, different group. Maybe they're not perfectly comparable on that basis. And you know that people differ in other ways that we don't even know. So as we select people, we may not even be selecting for the group that we thought we had. So we get to this quandary, does it work or not? The good news is I don't think we'll ever do another study because we have better things. Third clinical trial we're involved in, which hasn't been talked about much, is varenicline. I think most people have forgotten about it. You will recall in the literature there were case reports, of which I was an author, on individuals who carry a single point mutation and in conjunction with expanded allele, who responded dramatically in response to varenicline, as well as some people with other ataxias. Well documented. But that's only 2 people. So let's see what happens when you give it to a bigger group. And the original target enrollment was 32 individuals, 16 for drug, 16 for placebo. So it's a double-blind study. I don't know what the person's on. My co-investigator doesn't know what the person's on. The subjects don't know what they're on. 2 sites here in the University of South Florida. Our outcome measure was that exam-based measure, though we were doing everything. We only enrolled a total of 26 subjects. 17 people actually completed getting the drug. Why? Because when you oversee a study, there is always a safety monitoring board. The DSMB was looking at the data. They got to know what everyone was on. And they discovered that a large number of people were dropping out and getting worse who were on active agent. So the study was stopped after 26 patients due to increased ambulation imbalance in subjects who were on drug, an increased number of adverse events in the treated group, as well as the fact it didn't seem to be working. So the DSMB stepped in and stopped it. Good, because we were not helping people. It was statistically shown that we were making people worse, and that is the time we have neutral people stop it. So if you actually look at the adverse events, it's a little small. Drug is on that middle column there. Placebo is over here. One particular thing to note, this is the total number of adverse events. We give you a questionnaire and say what's going wrong. There are 64 adverse events in the placebo group. Okay? You wouldn't expect that taking sugar pills, I forget what the actual placebo group was, would cause adverse events, but if we ask you a bunch of questions, people will find things which might be adverse events. And the number actually in the drug-treated group were not that much more. But where it comes down to is when you look at the relationship of adverse events to study drug. When you tell us about something that's going wrong, the investigator or a safety monitor is asked, do you think that came from drug or not? And you can do it based on when it happens, things like that. It was felt that the adverse events in the drug group were related to study drug, were very few and much less in the placebo group. So this was giving rise to too many adverse events. And if you look at the bottom, this one right here, imbalance and really almost loss of the ability to walk in people who were previously ambulatory, only appears on the varenicline side and not on the placebo. So this study was stopped because of that reason. But remember, we started this study for a very good reason, that we saw people getting better when they took the drug. So is this a failed study? I will argue that no, it's not a failed study. It's a failed drug. We showed that it didn't work. But this trial did succeed in accomplishing the outcome of figuring out whether this is a good drug for people on average to take. And the answer is clearly no. But sometimes the answer that is right and that is correct and that you get is just not the one you wanted. Protecting people is equally important to making people better. So I will argue that this is a successful study because it showed how the process can go through and get us to the right answer. So now, we have one more study, which the results were shown at the ANA meetings in San Diego a week ago. A0001. What is A0001? It's a modified form of Idebenone / vitamin E. It sort of looks like you put them together. It's alpha-tocopherol-quinone. It's actually found in your bodies all the time to a very small amount. It's more potent than Idebenone. The slide I've taken here on the right is a dose-response curve. I have to show a little science. This is from Rob Wilson's group, done in collaboration with Amal Howie and Tom Sausher from Penn West. On the right is Idebenone. On the left is A0001. They're looking at the number of Fibroblasts, using a model developed by Helene Puccio up here at the front table, die in response to challenge and how much A0001 versus Idebenone can protect them. And basically what you see is that A0001 is about 1 order of magnitude, about a factor of 10 better than Idebenone in protecting them from that oxidative challenge. In addition, A0001 is absorbed much, much better. Now, you do have to do some things like eat fat. And when I was talking to one of the individuals from the trial the other day, I remember him saying that how much fat, he asked the question, how much fat are you required to eat and absorb A0001? And the answer was, as much as possible. So there are some adverse events. Maybe it doesn't, nothing, but you know, it's a trial. You have to do what we ask you to do. We get to make the rules here, guys. We call this trial FRDA 02, no names after Greek cities. It was done by Penn West Pharmaceutical with acetrop. It's double-blind, placebo-controlled, medium and high doses of A0001, 31 total subjects. We got to replace 1 dropout. It is a 1-month treatment. The primary outcome measures those people who participated know is that we would do this glucose tolerance test on you, where we shoot you full of a lot of glucose and shoot you up for a lot of insulin. We measure all these diabetic measures. Now, that's the primary outcome, but then we measure the neurological things as well. It's a reasonably tough protocol, and I'll note we're measuring the neurological outcome measures after we have put these people through these various IV treatments. Remember that when we come to generalizability. So what does it actually show? Well, the glucose outcome measures just didn't sort of work. They were very noisy, and we couldn't establish anything. However, the individuals on A0001 had a significant improvement in their FAR score. People on placebo got about 2 units better. People on low dose got about 5 points better. People on high dose got 6.1 units better. These are statistically significant, very high levels. It worked across all aspects of that neurologic exam. In addition, and this goes to the bottom point, it actually happened in just about every subject. So it was very uniform. This change wasn't driven by a couple people getting a huge amount better. It's actually every individual, except for maybe 1 or 2 getting better out of the 10. The improvement, this amount of improvement, you ask, well, how does that mean? It's about 6 points is about what people change in 1 to 2 years. So this would meet the definition of clinically significant. So, great outcome. What are the problems with this? Well, let's go back one. The problems, it's 1 month. You know, I brought it up earlier. What happens at 6 months? There's only one way to find out, and that's do the experiment. Yes, these were not the things we meant to measure as our primary outcome to begin with. We just found that they were better. You always have to be cautious in interpreting such things. Maybe it only happens if we give people an IV glucose tolerance test and challenge them and fatigue them with that. Don't know. If that's true, it's not so generalizable. That said, this is a very nice result. It's a reason to keep moving forward with this drug without doubt. And the question is, what happens if we give it to people for 6 months or a year? We'll see. So this is, I've stolen from my good friends at FRDA, the pipeline slide again. I think I copied this a while back, but I've added something over here to emphasize a new announcement. Right here at the corner, this thing called OX1. This is a new drug for which the safety data is available in adults, which has now been licensed to Viral Pharma for trials in Friedreich ataxia. Now, the one good thing about this is Jen and I might fly all around the country to visit various drug companies. They're local. We don't have to fly anywhere. So we can save some of our time, which is always a nice thing, and we can get back to more work for you. Works for me. Notice, though, in particular, the real emphasis here is not so much is on OX1, but also all the things on this list. That I mentioned A0001, but there are lots of other shots coming as well. And that's why I want you to know about all the details of these clinical trials so you can be active participants. And there are some things that we ask you to realize in clinical trials. Clinical trials are experiments. There are rules. Oh my gosh. Dave has to enforce a rule. We call them, in some cases, inclusion and exclusion criteria, that we write the study so that we can do the best, most generalizable experiment at the safest scenario for people. Sometimes we'll want to look at the individuals who are right in the likely to be most responsive window so that we can get the most reliable result. Sometimes we will exclude people in whom we are worried that they are more likely to have a safety event. That will be drug dependent, and sometimes as well as not drug dependent. We do this because we need to do it right. That said, they are largely inflexible. A few of them have interpretational components, and usually it's the principal investigator who gets to make those interpretations. So if you get excluded, it's unfortunately part of the game. If you get included, it carries that much more responsibility to do the right thing as you're there. There are also personal practicality issues. We set the visit schedule so that we can do the experiment right. For example, and Massimo emphasized this from the phase 2 deferriprone trial, which we were almost involved in many years ago. The first, because of the adverse events potential with that drug, the first 4 weeks involved 6 visits to the Children's Hospital of Philadelphia. Now, I don't even like to go to Children's Hospital of Philadelphia 6 visits in a month. I prefer to stay at home and work. But in any case, it's a rugged schedule for particularly people coming from out of town, but it was necessary for safety reasons, and it was non-negotiable. And the other thing is cost. It does cost money to get to the Children's Hospital of Philadelphia or to UCLA or to Iowa or Chicago or Minnesota or Emory or the other places I'm forgetting, Toronto or Melbourne or Brisbane. And I know I forgot someone, and University of South Florida, University of Florida. So it costs money to get there. I will compliment my friends at Santhera for in their trial, because they had such tight recruitment criteria, they actually covered the cost of everyone coming to CHOP for 9 visits over the course of a year and a half, which if you calculate it out, is about $700,000. It's not a trivial amount of money. Companies are not required to do that. It may affect their recruitment, their ability to move forward in a trial, but it's not a requirement. So as we move forward, the varenicline study covered only a minimal travel expense. A0001 had travel expense covered after the first screening visit. These are all things that you will have to consider as these announcements come up. So if you want to participate, what do? You sign up on the registry for the Friedreich Ataxia Research Alliance so that when that trial is announced, you will get an email. So I started this as a talk about neurologic function and the things which we're going to measure. So what's the upshot of clinical trials at this moment with that very encouraging result? There's reason to be optimistic. You know, we've done some trials. We have some which is neutral, one which showed that a drug didn't work, and one which at first glance, emphasis first glance, shows that a drug may well be efficacious. Let's see what happens long term. But I think the other thing which I wish to emphasize is the only way to truly move forward with a systematic approach and getting the answers. I think we've gotten the right answers, and the right answers are the ones which actually protect people as well as help people out long term. So at this point, I get to stop, and we'll go from there. Thanks. What's the time?